stand by. We are about to begin. Good day and welcome to the Healthcare Leadership Council Help Make IPAB Repeal a Reality conference call. Today's conference is being recorded. At this time, I would like to turn the conference over to Mary Greeley. Please go ahead, ma'am.
Thank you all for joining us today. I'm Mary Greeley, President of the Healthcare Leadership Council. Our organization is one of the leaders of Protect My Doctor and Me, a campaign dedicated to preserving a strong and a sustainable Medicare program and to ending the threat posed by the Independent Payment Advisory Board, or IPAB. The purpose of our webinar today is twofold. First, we want to provide important and valuable information about IPAB, what it is, how it would work, and what it would mean to Medicare beneficiaries. And second, we want to encourage all of you participating in this webinar to get involved in this effort, contacting members of Congress, speaking out publicly, using your social media channels, and we'll also be providing you tools to help you do that. So more on that later. We're fortunate today to have a number of expert presenters with us, and they're going to provide important factual information about IPAB and also describe how it will affect healthcare providers and patients. We'll be hearing from Josh Teitelbaum, counsel with the Aiken Gump Law Firm here in Washington, D.C., Dr. Angus Worthing, who's chair of the Government Affairs Committee for the American College of Rheumatology, Elizabeth Sump, the Senior Director of Health Policy for the Cleveland Clinic, and Bill Remack, founder and CEO of the California Hepatitis C Task Force. Now, before I turn to Josh Teitelbaum, I think it is important to note that the issue we're discussing today carries with it a great deal of urgency. People are paying more attention to the Independent Payment Advisory Board now than in years past because, according to the actuaries at the Center of Medicare and Medicaid Services, Medicare spending levels are on the verge of activating IPAB for the first time. Now, some believe mistakenly that this doesn't matter, that President Obama didn't name any members to IPAB, and there is no sign at the moment that President Trump will either. Regardless, under the statute that created the board, IPAB powers then shift to the Secretary of Health and Human Services if there are no board members. That is a tremendous amount of power in the hands of one individual, regardless of their political party. And that's why we need to act now. We all agree that steps can and should be taken to bring greater value to the Medicare program. But IPAB doesn't do that. It requires that Medicare expenditures be reduced to an arbitrary level within 1 year. That doesn't improve Medicare. It simply affects the access to care and the quality of care for beneficiaries. We're hosting this webinar today because we believe repeal of this ill-conceived idea is eminently possible. There has always been bipartisan support for IPAB repeal in Congress, and as Josh will explain, the urgency of this issue is now bringing more members of both parties forward to support repeal legislation. And Congress is well aware that over 670 organizations from throughout the country, representing patients, physicians, hospitals, employers, veterans, Americans with disabilities, and others, are insisting that IPAB should not be empowered to harm the 55 million Americans who depend on Medicare. This support for repeal is both strong and growing, and now we need Congress to act. So with that, to provide more detailed information about IPAB and the repeal effort, I'm very pleased to turn the program over to Josh Teitelbaum with the Aiken Gump Law Firm. Josh?
Mary, thank you so much for that kind introduction, and I could not agree more that there is no more important time than now to be involved in trying to repeal the Independent Payment Advisory Board. As Mary noted, I'm happy to dive into the details a little bit more about how the Independent Payment Advisory Board works. I think to do so, we'll have to temporarily take ourselves back to the context of 2010, when the overriding conversation around healthcare policy centered around excessive growth in the annual cost of Medicare as a program, and there was a great deal of effort put into developing proposals that would rein in that excessive spending. One such proposal obviously became the Independent Payment Advisory Board, which Mary noted established this board comprised of 15 members nominated by the President and confirmed by the Senate, who may not hold any other outside employment during his or her tenure on the board. The intent was for these members to be independent and propose findings in Medicare should spending exceed a projected growth target that would be independent and presumptively go into effect. The trigger that Mary referred to happens if the CMS actuary projects that Medicare spending will grow more quickly than a target growth rate. If it does, the board's 15 members are charged with developing proposals to find a specified amount of savings in the Medicare program. Initially, the target growth rate is a blend of medical inflation and general inflation. However, beginning in 2018, the target growth rate is GDP plus 1%, and the savings target is a percentage of the difference between the projected growth and the targeted growth rate. As I'm sure everybody on the line is familiar with, historically, medical inflation has been growing at a faster rate than general inflation or GDP and even GDP plus 1%. So the expectation is that as we shift formulas, it is increasingly likely that the CMS actuary will find on a more regular basis that the IPAB is triggered and its requirement to find savings happens on a more regular basis. As Mary noted, there is also a fail-safe. If the board fails to deliver its proposals, for example because there are no board members, then the authority to develop these proposals is delegated to the HHS Secretary. Since its enactment, no board members have been nominated and none have obviously been confirmed. As a result, today the authority to propose Medicare savings rests solely with Secretary Price. The proposals that the board and the Secretary in its place must develop do have some guardrails that are included within the statute. They may only relate to Medicare. They must result in a net reduction of total Medicare program expenditures at least equal to the savings target, and it may not ration care, raise revenues, raise premiums, increase cost sharing, restrict benefits, or alter eligibility. Unfortunately, there is a lack of enforceability with respect to these guardrails because of an explicit provision in the statute that prevents judicial review. If the Secretary or the board members were to propose Medicare savings that exceeded or moved outside of the guardrails that we just discussed, there would be no way for the groups on this call or others around the country from ensuring that no such proposals took effect. In addition, once proposals are made, they are designed to achieve the savings target in a single year. Before those savings may take effect, however, they are considered by the administration and by Congress. The board's proposals or the secretaries are submitted to the White House and then to Congress, who must consider the proposals under fast-track procedures. Congress may only amend the IPAB implementing bill by finding at least the same amount of savings as in the board or secretary's plans. Senate floor time is limited, and the motion to proceed is non-debatable. In other words, the statute guarantees a vote for the IPAB board's proposals. If we can put together this timeline of determination, proposal, and implementation, this is what that calendar were to look like. Under the statute, the CMS actuary must make its determination by April 30th, 2017. We then begin a process of proposal development, submission and review by the administration, and submission to Congress in 2018, and consideration of any alternative proposals. If none are enacted finding the same or greater amount of savings, then those proposals will take effect beginning with fiscal year 2018, depending on where the proposals target their savings, either October 1st or January 1st, 2019. As Mary noted, we expect that the CMS actuary will find that IPAB is triggered this year for the first time. That finding is backed up by the Medicare trustees' most recent estimates from summer of 2016, as well as the CMS actuary's most recently published data in Health Affairs, who also confirmed in a press conference at the time that this data confirmed that they expect IPAB to trigger this spring. Those numbers also estimate that IPAB will again trigger in 2022 and 2024, with cuts required in the implementing years to follow. By the third cut that is triggered under the current estimates, the savings target reaches as high as almost $20 billion to be implemented in a single year. Now, with your support and with the increased urgency that comes from an expected trigger this year, support for IPAB repeal is growing. Senator Cornyn has again introduced legislation to repeal IPAB and has the support of 28 co-sponsors. And Senator Wyden has introduced similar legislation that would also repeal IPAB that has 7 co-sponsors. Support for both bills continues to grow and is bipartisan. In the House, Representatives Rowe and Ruiz have also introduced a bipartisan bill whose support continues to grow. We continue to meet with members in both the House and the Senate who are interested in reviewing the bill. And as Mary noted, no time is more important than now to express your opposition to IPAB.
Great. Thanks, Josh, for that explanation of the whole process. Now we'd like to take a moment and hear the physician perspective from Dr. Angus Worthing of the American College of Rheumatology.
Yes, on behalf of the American College of Rheumatology, I'd like to thank the Healthcare Leadership Council for the invitation to be included in today's call. ACR is the National Organization for Arthritis Specialists in the U.S., and we strongly support repeal or significant modification of the IPAB provision of the ACA. Our reasoning here is that we believe Medicare should ensure adequate access for seniors to see their doctor and specifically their rheumatologist. ACR does support many of the patient-centered principles around our current healthcare reform debate. For example, not allowing pre-existing condition exclusions, allowing kids to stay on their parents' plan to age 26, and others. But with IPAB, our concern is that this unelected board could take action to reduce reimbursement to physicians for their services, which would further the recent decade of inflation-adjusted cuts. And this would likely reduce seniors' access to see a rheumatologist. Specifically, a little bit about us, seniors may lose access to cognitive specialists whose clinics primarily are funded by reimbursements for services in office visits instead of procedure services. So clinic viability is very sensitive to cuts in reimbursement for these kinds of services. And if reimbursement is reduced, the clinic viability is reduced, and doctors may not be able to see Medicare patients, and people would lose access to their doctor. So ACR believes that this is not the appropriate way to curb healthcare spending. The risk of harm is too great when responsibility for Medicare decisions is mired in these additional levels of bureaucracy, particularly one that is immune from congressional oversight and not accountable to all stakeholders. So again, we do strongly support repeal or modification of the IPAB. Thanks so much for letting me participate in the call.
Great. Thank you so much for sharing that. I think it's really important for people to see the real impact of those potential cuts. Next, we'd like to hear from Elizabeth Sump, who will give us the hospital perspective, and Elizabeth is with the Cleveland Clinic. Elizabeth?
Hi, thanks so much, Mary. Good afternoon. My name is Elizabeth Sump. I'm with the Cleveland Clinic, which many of you may know as a healthcare system, but in reality, we are an integrated group practice. We have more than 3,500 staff physicians under full employment with the Cleveland Clinic. Last year, we saw more than 7.1 million outpatient visits and had more than 220,000 acute admissions and observation stays. I want to emphasize our status as an integrated group practice because our physicians already are being paid based on a salary basis and not based on their fee-for-service. The way in, they're not being paid based on the number of procedures they do or the number of tests they order. And so we already are working under a very strong value-based delivery model and not based on not on a volume-based delivery model. And while Cleveland Clinic has tended to be a little bit ahead of the curve, I would say that our story is not unique amongst hospital systems today. Most hospital systems are moving to a more value-based system for care delivery. And that works really well so long as we can anticipate what our reimbursement rubric looks like going into each year. IPAB, should it be triggered, leaves us in a position where we are now not sure of what sorts of cuts we might be facing in a very short time frame. And that makes it very difficult for us to allocate resources properly. It makes it difficult for us to plan around structural changes and changes to our care delivery models that otherwise might deliver better care and better quality for a better price. And so we are strongly opposed to IPAB. We strongly believe that it needs to be repealed, and we think that most Medicare savings can be realized through value-based models that are already emerging and haven't had a chance to fully play out and reveal what their value is going to be in the long term.
Great. Thank you so much, Elizabeth. Our final speaker is going to share with us the patient's perspective. Bill Remack of the California Hepatitis C Task Force. Bill?
Thank you, Mary. Thank you for inviting me on the call. The patients in California that have hepatitis C have a very significant burden to address and how it affects our entire healthcare system. As many of you know, there are now several drugs available to treat hepatitis C, and they're upwards of 95% and above effectiveness in eradicating the virus completely. But in the state of California, there's still an estimated 300,000 to 400,000 people that are Medicare beneficiaries that will need to be treated for this disease. And fewer than half of them are aware they have the infection, so they need to be tested. There is no vaccine for hepatitis C, and once infected, an early diagnosis can prevent health problems that eventually will become either advanced cirrhosis or liver cancer, or even the possibility of needing a liver transplant. And also infecting other individuals. So we need to have, first of all, an assessment of the liver damage, the fibrosis or cirrhosis, and the degree of infection. And this can also be done by a liver biopsy or a fibroscan, a test which is a non-invasive scan. There's still hundreds of thousands of individuals needing treatment, and if the IPAB's payment cuts to healthcare providers occurs, it would be devastating because we already are working with very narrow networks, and increasing a limited access to care will only cause those conditions to become more serious, requiring a far more costly intervention to retard the progression of the disease. We do have some rationing in other systems, and we're working very diligently to resolve those as well. Medicare beneficiaries right now are fortunate to have fairly reasonable reimbursement rates for physicians, and if that was to change, we'll see a number of them drop out of the system.
Right, Bill. Bill, I think you're giving us a very important message, and I think one that will resonate well on Capitol Hill with legislators, and that really is about the access to care. I find it interesting, as Josh has described to us, IPAB is not supposed to affect beneficiaries. And I don't think that the people writing this legislation really understood, as you're describing, the real impact of IPAB will affect beneficiaries through decreased reimbursement to providers and giving them fewer providers to where they can access the services that they need. So thank you for sharing that important message with us.
Thank you. The National Association of Hepatitis Task Forces and the California Hepatitis C Task Force strongly oppose the Independent Payment Advisory Board and encourage Congress to pass a repeal legislation before these cuts are enacted.
Great. Thank you so much. Well, I think it's important to know that right now we have real momentum on our side in the drive towards that IPAB repeal that you've heard each of our speakers endorse. More members of Congress every day are becoming aware that IPAB, if triggered into action, will be detrimental to patients and healthcare providers. But we're not there yet. We still need more lawmakers on board to ensure the passage of the repeal legislation. The most effective way to do that is to make sure Capitol Hill is hearing your voices. So we are dedicating next week, from March 6th to 10th, to amplifying the IPAB repeal message, ensuring that every member of Congress hears that message. We have over 670 organizations that have signed a letter urging repeal. So now we're asking every one of these groups to submit an op-ed to a local newspaper or to write a letter to the editor. We're asking that you email the healthcare legislative assistants for any member of Congress with whom your organization has a presence. We're asking all of you to use your Facebook page and Twitter feed to carry this message forward. If every one of our partner groups, all 670, does at least one of these activities, and hopefully more, then this message will resonate. We've put together toolkits that contain templates for all of the items that I've mentioned, as well as email addresses for Capitol Hill Health LAs and Member of Congress Twitter handles. If you haven't yet received one of these toolkits, please contact Mike Freeman of our office at the email address that you have on your screen, and then we'll get those materials to you immediately. We're at a critical point right now if repeal is going to happen before IPAB can do very real damage. So we look forward to working with you to make this message heard. So right now, I'd like to take some time. We'll open the lines for questions.
Thank you. If you would like to ask a question, please signal by pressing *1 on your telephone keypad. If you're using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. Again, press *1 to ask a question. We'll pause for just a moment to allow everyone an opportunity to signal for questions. And we will take our first question from Thomas Berger.
Thank you. Tom Berger from Vietnam Veterans of America. Along with my colleague there, Bill Remack, we do a lot of work on Hep C, plus a number of other diseases that afflict our veterans. In any case, during the course of efforts over the last couple of years to repeal IPAB, I often hear comments about the process being unconstitutional because if certain things aren't met, then the Health and Human Services Secretary can make the decision without judicial review. Is that a valid point to make? Still a valid point to make when you're talking to people up on the Hill?
Hi, Tom. This is Josh Teitelbaum with Aiken Gump. Yeah, right. I would say that this is not just a valid point, but a point that is certainly resonating when we speak with staff members on the Hill, and we discuss how there is a lack of judicial review for Secretary Price's possible reforms. A number of offices have expressed concern about Secretary Price's recommendations for changes to Medicare when he was a member of Congress, and now that he has moved positions, I understand that a number of offices have concerns about that, and the inability to review some of those decisions has helped drive some support for Senator Wyden's bill. When we discussed this message with the supporters of Senator Cornyn's bill, there is also a strong concern about the lack of judicial review. And so we do encourage you to bring this point up with staff members in your contacts with them, whether that be by email or otherwise.
Thank you.
And if you find that your question has been answered, you may remove yourself from the queue by pressing *2. We'll take our next question from Brad Crone.
Hey, I keep hearing about the accountability issue with Congress, and I was wondering if you could discuss that, about the fact that Congress in the ACA basically ceded away some of its authority to manage and to govern and legislate over the Medicaid program. Isn't that a major component of this?
Yes, absolutely. This represents a significant delegation of authority from Congress to the executive branch to develop Medicare policy that has historically been Congress's responsibility. That is a concern that has resonated with members of Congress and their staffs ever since we have been meeting with their offices this fall. And actually, I think points to the long bipartisan history of opposition to IPAB, beginning even in 2009 when it was first proposed. In 2009, in the House, there was bipartisan opposition among Democrats and Republicans who were concerned that delegating the authority to 15 unaccountable, unelected members of this board would be devising policy on how to deliver care to Medicare beneficiaries. That is traditionally a responsibility that members of Congress prize and are interested in protecting their seniors' care. So we often talk about that in our meetings with members and their staffs. Absolutely.
Thank you.
Okay, we have a question online. Is the Health LA email list included with the toolkit?
Yes.
Freeman?
Yes, the emails list and the member of Congress Twitter handles will be included with the toolkit.
And the next online question, are there currently any members named to the board already? And if so, how many are there and who are they?
There have been no members nominated for the board or confirmed, obviously. That was a decision made early on, and no names have been submitted since, and we do not expect any to be forthcoming from the Trump administration.
So that makes it clear that the authority would probably automatically default to the Secretary of HHS.
Absolutely.
All right, well, hearing no more questions, I just want to, again, thank everyone for joining us today. Josh, thank you for a great description of IPAB and how it works, and our other speakers. But I also want to thank all of you for everything that you'll be doing on this issue, particularly next week, to help encourage IPAB repeal. You can learn more about all of this on our website at www.protectmydoctorandme.com. We also hope that you will join our Twitter feed at MyDoctorAndMe. So thank you, everyone. Please contact us if you need any information, and I want to thank all of our speakers today as well. Have a good afternoon, everyone.
This concludes today's call. Thank you for your participation. You may now disconnect.